Good afternoon, everyone. Can you all hear me? Can you all hear me?
We can hear you.
Oh, super. Sorry, I'm hiding inside the house so that my daughter does not listen to this lecture. So anyway, let me start. So you're fourth year students? 96 batch, right? 2006 batch, 2016. Yeah. Right. So today we are going to discuss about sexual dysfunction. I think this is very important topic for anyone, because anyone has his or her own sexuality, and it's quite common for people to experience problems with sexuality or sexual function. So as individuals, it's very important, but as doctors, it's even more important, because a lot of, irrespective of what specialty you take, as medical students, a lot of people will come to you asking solutions for sexual problems. And as doctors, irrespective of the specialty, people, you will encounter people with sexual problems. So you have to have some good understanding about common sexual problems or dysfunctions and how to help them. So let's look at the normal sexual response cycle. In men, it's very straightforward. There is excitement phase. You know what happens in the excitement phase. There is increased the pulse, that is heart rate, and the increased circulation, and the erection, and then there is a plateau phase, and then the orgasm, and then the resolution phase. The resolution is with the resolution, people or men can have a period, we call it a refractory period, where you can't get another erection. So this the refractory period can vary from one person to one person, and mostly dependent on the age. Young people have very in the teenagers, and in 20s, the very short refractory period. But as we grow older, it can go lengthen up, and sometimes it can be few days even for a elderly man. Then we have the sexual response cycle in females, which is not really straightforward. In females, there is, of course, excitement phase, and then there can be a plateau, and then many women in normal intercourse might not achieve the orgasm, so they just go into resolution phase without an orgasm. But often the women have the capacity to reach an orgasm, particularly with the self-stimulation or masturbation, and also in vaginal and other forms of sexual activity. And not only an orgasm, they have most women have the capacity to reach multiple orgasms. So why one orgasm for a man and multiple orgasms for women? Anyone? Anyone? Gajaba? No one has any idea? Okay.
So the intense.
Sorry? Sorry, I couldn't hear properly.
So the intensity in women's orgasm is kind of, I think, I don't know for sure, but it might be less intense than the men's one. But so that may be a reason why males have just one orgasm and they can be refractory for the period, but women can go on for long, but it may not be as powerful as a medicine?
I think it's a fairly valid explanation. Taridu, right? So you have a potential to become a sexologist. Well done. But my explanation is actually the women for them to engage in sexual activity evolutionarily. It's a more riskier thing. Like, you know, it can lead to pregnancy. So it has to be very satisfying for a woman to get into this. So maybe that, but these are just different thinkings or theories. This is my own theory, but there are different things different people can say. So Tharidu's explanation also may be possible. Anyway, so the learning is that men's sexual response cycle is quite straightforward, but women's it may not be that straightforward, and women often do not reach in normal sexual activity. Not often, significant number do not reach orgasm, but they have the potential to reach multiple orgasms. So let's move on to the factors that affect our sexual function. This is, I think, is the most important thing to understand. And for a normal sexual function, we need good physiology. That is, like, you know, your endocrine system, the vascular system, the nervous system, has to, and the vascular, endocrine, and the neurological system has to function properly. That physiology is very important. But at the same time, just having normal anatomy and the normal endocrine system, vascular system, and the nervous system does not suffice, because the psychology, the mind is also very important. So when someone is depressed, his or her expression of sexuality can be very different. And when someone is overjoyed, or very happy, then they might the expression of their sexuality can be a little different. So the psychology or the mind plays a very important role in expressing the sexual or in the sexual function. Then there are two other important factors: the socio-cultural influences and the interpersonal relationships. So in a setting where they are exposed to a lot of myths and misconceptions right from the beginning, can affect their sexual behavior and sexual function and the expression of sexuality. And similarly, someone who has perfect physiology, perfect psychology, and without having any significant negative sociocultural influence, can still have problems with sexual function with his partner, his or her partner, because they do not have the perfect relationship. So interpersonal relationships play a very important role in sexual function. So when you encounter a couple or a individual with a sexual problem, you have to look at all the dynamics. I think this is very, very important. Otherwise, you are just treating a symptom and without identifying the real cause of it. I see a significant number of sexual problems are actually interpersonal or relationship issues driven. Or like there can be a sexual problem, but it is precipitated or it is maintained due to interpersonal and relationship issues. Then there are different classifications. WHO has their own classification on sexual dysfunction. Then there is ICD-10 and ICD-11, which will come to effect from 2022. And then American Psychiatric Association have their own classification, and the DSM-5 released their classification in 2013. Then we have ISSM and that is International Society of Sexual Medicine, and American Urological Association. They have their own classifications. Then everyone got together and developed the committee, which is called Fourth International Consultation on Sexual Medicine, and ICSM, and they have defined most of the sexual dysfunctions, which are actually most commonly accepted definitions right now. And I'm actually referring to those sexual the ICSM, which is actually part of ISSM. ISSM nominated this committee. So I'm referring to those classifications. When you look at female sexual dysfunction, there are 4 main categories. First one, the hypoactive sexual desire disorder. Second one, female sexual arousal disorder. This is desire is very clear. But when you say arousal, what do you mean by arousal? Arousal is the changes that appear in the vagina and the vulva, like lubrication, vaginal engorgement, and the clitoral engorgement. And lack of this is sexual arousal disorder. Similar condition in men is called erectile dysfunction. Then we have orgasmic dysfunction, and then we have sexual pain problems, particularly dyspareunia and vaginismus. There are less common sexual dysfunctions, which I will just briefly introduce. I don't think you need not know details about those. The first one is the persistent genital arousal disorder. In this situation, the women get the urge to masturbate, and even after masturbation, there's no satisfaction. So they keep on masturbating without much of a desire. So it's like, it's a genital arousal without without much of an increased desire. And then the postcoital syndrome. This is negative feelings or experiences after sexual activity. Then they have women can have hypohedonic orgasm, which is it can be lifelong or acquired, which is low pleasure with orgasm. Then we have painful orgasm, and also that is during the orgasm and following orgasm pain. Out of the 4 conditions that I mentioned as the important female sexual dysfunction, I thought I would share 2 important conditions. One is hypoactive sexual desire disorder, that is the persistently or recurrently deficient or absent sexual fantasies and desire for sexual activity that causes distress or interpersonal difficulty. So this very important to remember. It's not just the absence of sexual activity, it's also absence or significantly diminished fantasies, because someone could avoid sexual activity with his partner or due to other reasons other than desire. She may be having desire, but she may have problems in expressing that. So by asking her whether she has sexual fantasies or whether she gets sexual thoughts, you can verify whether she has actual sexual desire. So when you define or diagnose hyperactive sexual desire disorder, one should have diminished fantasies as well. So it's very important to identify the the history, and how long she has had this problem and what has triggered it, and the partner dynamics, and why she's having sex, what is the motivation, and whether there are the other inhibitory factors. John Bancroft, he defined a model called cis and sets, or the dual control model, which is the female sexual desire is a balance between excitatory and inhibitory factors. So you have to analyze what are the inhibitory factors, what are the excitatory factors in a female with the desire disorder. So when you look at biological factors, the commonest is I wouldn't say commonest, a common cause is hormonal, and particularly hypothalamic pituitary gonadal axis disorders, and the commonest is surgical menopause. As doctors, when you particularly, I think this is mostly related to gynecologists, so the people who are working in a gynecological setting, after the removal of ovaries, I see many women are not started on the hormone replacement. I think for a younger woman, it's a crime, because her sexual desire can be seriously affected subsequently. So, and quality of health and well-being. I'm not going to read out the drugs. I will give you. I will share this lecture note so that you can go through the drugs and the other factors. Also remember that OCP can reduce sexual desire in certain women, mainly because it has it increases sex hormone binding globulin, and sex hormone binding globulin binds whatever the testosterone tightly to it, so that active or the active or the free testosterone can be low. So even females, the sexual desire, the testosterone has an important role in sexual desire. So by this mechanism, the females on OCP can have a reduced sexual desire, but it's not a very common thing. It doesn't affect every woman. Certain women, it actually increases sexual desire because their fear for pregnancy is gone, and they are more comfortable. So there are other dynamics also playing. Then the quality of health and well-being, extreme tiredness and other comorbidities like diabetes, COPD, CKD, all these can cause the desire disorder. And I see extreme tiredness, a common problem, like, people leave home 4 o'clock in the morning, and then they come back late in the 7, 8, and very tired, no time for relaxation, no time for exercise. All these factors affect sexual desire. Then the mood and the medication, again the list I will share. Particularly, you remember antipsychotics and antidepressants can affect sexual desire, and also the certain anti-lipid drugs like atorvastatin can also reduce sexual desire in certain women. Then we have to assess motivational factors. Why this lady or woman is interested in sex? What motivates her? And whether it's for procreation, recreation, or is it to serve a specific purpose, to please someone? Also the cognitive factors, wishes, and the risks, whether she has a safe environment, and whether she has safe partner, whether she is comfortable with this partner. All these factors play very important roles. So the management, the psychosexual counseling addressing these psychological factors is very, very important. Then addressing relationship factors with relationship counseling, correcting any underlying hormonal abnormalities is very important. And then if there's any medical condition that is causing or medication that is causing, we can correct those. And sometimes very rare situations we use off-label testosterone, because testosterone is not licensed to treat female sexual desire, but it can be used in low doses under specialist care. And the only FDA-approved drug for female sexual dysfunction is flibanserin. It's a 5-HT1A agonist and a 5-HT2A antagonist. It is called ADI, the trade name, the brand name, but it is not available in Sri Lanka, and it's the only drug registered to treat female sexual desire. Let's move on to the second common female sexual dysfunction, which is the vaginismus. It's very common in our setting. I practiced sexual medicine for 5 years in the UK. All the women that I had seen during that 5 years with vaginismus are from South Asian origin, either Sri Lanka, Pakistan, Bangladesh, India, these countries. So it has a significant cultural background to its etiology. It's defined as recurrent or persistent involuntary contraction of outer third of the vagina interfering with sexual intercourse. This is very important to understand that it's involuntary, not a voluntary contraction, and it's in the outer third of the vagina, and it has to be persistent to make a diagnosis of it. And there are four types. One is primary, that is when someone has never been able to have intercourse. Then secondary, when the one has been sexually active in the past and developing vaginismus secondarily. I see in our setting, I had seen a lot of secondary vaginismus as well. Sometimes it's not exactly vaginismus, it's voluntary contraction of the outer third of the vagina because of the fears of proving virginity. So you might encounter such girls. So help them, tell them that maybe you can do or guide them for a dilatation, so that the partner understand that her virginity is gone through the dilatation of the finger insertion. Not so there are concerns regarding virginity can also be sorted at the same time. Then it could be global. Global is like in the fear or the inhibition is not only for the penis. They can't accept any thing inside the vagina. It could be a tampon. It could be the vaginal scanner. It could be the finger. They fear inserting anything into the vagina. And then we have situational vaginismus, where she is okay for finger, the dilator, or even with other instruments, but not with the penis. So again, the treatment is very important for us to understand the phobia, what fear this girl has. Sometimes it's just a superficial fear. Sometimes it's the deep phobias, and they can have coexisting other phobias. And simple sex education guided to explaining how it works. It's just vagina is not a open tube. It is surrounded by muscles, and these muscles if they go into spasm, it can be painful, but when they relax, it's often can stretch and can accommodate. So simple advice, and then the treatment is systematic vaginal desensitization. So insertion of trainers under control. If you don't have trainers, you can start with the finger, then the sharing the control with the husband. First, she can do it herself, or the doctor can do it certain situations, and then sharing the control with the husband, and then we advise them to have the woman to be in control, so that the man doesn't poke the penis in without any control, so that even after dilatation or whatever, like, if they can accommodate 2 fingers even, if the man is also not very caring or careful, or can control, it can recur. So, but when the woman is in control, she can't hurt herself, so she will gradually, slowly do the insertion, and then once they are successful with woman on control, or the woman on top position, they can change the position and give the man the control. And so I'm discussing only 2 conditions, the 2 common conditions for the female sexual dysfunctions, that is the desire disorder and the vaginismus, because those 2 are the commonest the problems in our setting. And also you might encounter a lot of the desire discrepancies in practical settings. If we have time, after this lecture, we can discuss some of the questions, and depending on the time availability, whether you have another lecture. Then let's move on to male sexual dysfunction, and the first one is hypoactive sexual desire disorder. Fortunately, this is not that common among men. Then we have erectile dysfunction, which is the commonest male sexual dysfunction. Then we have ejaculatory dysfunctions. Under ejaculatory dysfunction, we have premature ejaculation and retarded ejaculation. And let's discuss then there are a few less common sexual dysfunctions, male sexual dysfunction. One is retrograde ejaculation, that is they reach orgasm, but the ejaculate or the sperms does not come out, it goes back to the bladder, and it's common in neurological conditions, and also in the diabetic patients. Then anejaculation, the absence of normal antegrade ejaculation. Then we have anorgasmia, and this is a difficult condition to treat, but it's not that uncommon. Then painful ejaculation or painful orgasm. This is also not that common, but you'll encounter these men as well. Out of the 4 conditions, the 4 main conditions, 3 main conditions, I will discuss erectile dysfunction and premature ejaculation briefly. Erectile dysfunction a little in detail, because it's common, and it is very important for you to know basics and help people with the problem. It's defined as inability to achieve or maintain an erection for satisfactory sexual intercourse. It affects men beyond their physical inability. Their psychological trauma or the emotional or psychological pain can be devastating. This is a schematic diagram of the penis during the flaccid or non-erect state and the erect state. There is you can see sinusoids lined with smooth muscle cells, which we call the corpora cavernosa. And with the sexual stimulation, there is increased blood flow to the corpora cavernosa, and this the drainage, the blood drainage or the venous drainage is blocked when the emissary veins are pressed against the tunica albuginea. The tunica albuginea is the thick capsule around the penis or the corpora cavernosa. So then there is the blood flow and reduced venous drainage. So there is increased blood pressure inside the penis, causing the erection. I think it's very important also to understand the molecular biology of erection, because with that you understand the pathophysiology of erectile dysfunction. This is a smooth muscle cell. I mentioned just a little while ago that smooth muscle relaxation leads to the increased blood flow. The corpora cavernosa, the blood filling is or the engorgement is mediated by smooth muscle relaxation of the penile arteries and the corpora cavernosa, which leads to the increased blood flow. So this is how what I'm trying to explain here is the mechanism of the smooth muscle relaxation. Smooth muscle is in a tonic contraction by the calcium locking mechanism. Efflux of calcium leads to smooth muscle relaxation. So this efflux of calcium is mediated by nitric oxide. Nitric oxide is predominantly released by the endothelial cells. In addition to endothelial cells, there are parasympathetic and cholinergic nerve endings that also secrete nitric oxide. So these nitric oxide stimulate the cyclic GMP pathway, which leads to efflux of calcium. The cyclic AMP pathway also responsible for this smooth muscle relaxation, but I will explain that later. What is important here is to understand that the cyclic GMP pathway leads to smooth muscle relaxation, the calcium efflux, which leads to smooth muscle relaxation, and it is predominantly mediated by nitric oxide secreted by the endothelial cells. So endothelial cells they play a very important role in erectile dysfunction. Okay, so let's look at the prevalence, how common this problem is. There are so many studies explaining or giving different data, but the most accepted and referenced study is the Massachusetts male aging study. By the age of 40, at least 40% of men have some degree of erectile dysfunction, but only 7% will have severe or complete erectile dysfunction. By the age of 70, about 69% of men have some degree of erectile dysfunction. Out of that, about 20% will have severe or complete ED. Let's look at the risk factors. The vascular risk factors are very important because, as I mentioned, it's a vascular event. Erection is a vascular event. Neurogenic, hormonal, anatomical and structural issues, the drug-induced, psychogenic, and mixed. Very important for us to understand that even though it's a vasculogenic process, the psychological factors are very important. Because when you're having anxiety, when you are depressed, this mechanism does not work, and even those who are having physical problems, it could be diabetes, it could be vasculogenic, whatever the reason, they also have psychogenic the psychological factors, because the failure can lead to more anxiety, and it can go into a vicious cycle. So always, even if you find a physical problem, look at his psychological fears, anxiety, because mixed etiology is very common. So when you look at psychological causes, fear of performance or rejection is very common among young boys, and I would say this is the commonest thing. Like, they can achieve good erection with masturbation. They get normal morning erections, but when they try to have penetrative sex, or mostly with penetrative sex, they lose the erection because they fear that they will not be able to do it, and then this gets into a vicious cycle. The next time the anxiety is more. So inadequate sex knowledge, lack of experience, lack of privacy, and the lack of privacy, I see a common problem in certain situations in our part of the world. Like, most of the with the extended families living together, most of the young people are having sex with the fear of parents noticing, and the mature people are worried that their children will notice. So, like, there's the privacy issue is a common problem in this part of the world, and so these simple things we have to always look into. Otherwise, you just subject these people for unnecessary investigations and unnecessary treatments. The guilt feeling, sex is a sin, sex is dirty. These are sometimes the misconceptions people have due to religious or cultural influences, and the defenses against erotic feelings, because some people try to suppress erotic feelings, thinking it's bad. Lack of sexual intimacy. Then again, in Sri Lankan settings, the women expect just the penetrative sex for the purpose of having a baby, and they don't have intimacy, and the man does not get proper stimulation. Lack of arousability. Then the first failure after failure. I had a man who experienced like, he couldn't do it on the first night, and the woman didn't say anything, but she looked at him in a way that like, oh, you can't do this. And each time he tries to have sex, he sees this face. It comes to his mind, and he loses erection. And sometimes it's just like in this situation, it's just a look or a stare. But sometimes the how women react also can have long-term impact. Sometimes when when the man couldn't do it, the woman also get upset. You can't blame them, but they interpret it differently. Sometimes they think that it's their problem, and they start crying. And sometimes they think that the man has another affair or is not interested in her. So I have seen situations, the women abusing men, both verbally and physically, sometimes just crying. So all these can actually lead to more failures after this one episode of failure. Severe premature ejaculation, if that is also not that uncommon. We call it antiportal ejaculation, or ejaculation happening prior penetration. And the 5% of premature ejaculation is this. That is 5% of premature ejaculation is antiportal ejaculation, and they might take the long time to get another erection, as we call there's a refractory period, and this can be a cause for the erectile dysfunction. Then an ejaculation, because the man does not ejaculate, he keeps on going and then get tired and lose the erection. And the vaginismus and dyspareunia are common causes because you try to penetrate and the penetration is not possible because the vagina is too tight. It either bends or the man loses erection, and it then again gets into that vicious cycle. And making a baby, this is very common in our setting. The woman or the lady is given the medication to induce the ovulation, and then they are asked to have sex on a specific day or every other day, depending on the gynecologist. So it creates a lot of pressure for the man, and also if the man doesn't there are two things. One is that the even woman doesn't do it with a desire. She does it for the sake of making a baby. So her sexual expressions and the excitement may be low, so which leads to reduced excitation for the man. And that's one aspect. The other aspect, it's not that common. I have seen, though, the man doesn't want a baby with this woman. So that situation also has seen the stress, pressure to perform during fertile period, which I mentioned. The stress is very common. The interpersonal conflicts I mentioned, suppression or expression of anger, when it can be both, like, when someone is suppressing the anger, I ask the partner whether she gets whether she's hot-tempered, and sometimes the man is scared to say that yes. So sometimes I see saying that in his eyes, or just with his facial expressions, I realize that it's that this partner or the woman is hot-tempered, and sometimes if the man is sensitive, it can affect, and when he tries to have sex, it can be expressed as erectile dysfunction. Depression and low desire can also cause the erectile dysfunction. And I mentioned this prior, that in an anxiety situation, it's the adrenaline and noradrenaline that binds with cyclic KMP, which inhibits the calcium efflux, which can lead to the smooth muscle contraction and the losing the erection. That's the mechanism of psychogenic AD in the smooth muscle cell level. And when you look at our evolution, we see that our risk for erectile dysfunction or vasculopathy or endothelial dysfunction is getting our risk is more and more with time, because we've been the hunter-gatherers searching or hunting for food, and then with the agricultural revolution we started farming, which was 20-30 times more efficient than hunting or searching for food. But now the modern humans, we spend most of our time either seated in front of a computer, so we are burning less calories during work as well as during day-to-day activities, but we are exposed to more calorie dense, more palatable, refined food stuff, which has led to the epidemic of diabetes, hypertension, hyperlipidemia, obesity. All these conditions are the major risk factors for erectile dysfunction and endothelial dysfunction. As you know, endothelial dysfunction precedes endothelial dysfunction precedes and predisposes for atherosclerosis and the ischemic heart disease and other vascular disease. So this is not apart from these psychological factors that I mentioned, this has a strong the physical component, that is endothelial dysfunction. Never ever ignore the endothelial dysfunction, identifying endothelial dysfunction by identifying the risk factors for endothelial dysfunction in a man with erectile dysfunction, because this way you can prevent the ischemic heart event, ischemic heart disease in this man, because it's a very early sign. Erectile dysfunction is a very early sign of atherosclerosis, very early sign of ischemic heart disease. So I think if you learn this, this is very important, and for your health, this endothelial dysfunction starts very early, and so have an active lifestyle. Spend more time with for exercise, and avoid smoking and the other risk factors, so that you don't get endothelial dysfunction and erectile dysfunction later. Right. So the neurogenic factors, and are we have to stop at 3:15 sharp, or is there another lecture afterwards?
Don't have it.
Sorry, you don't have another lecture?
No, sir, we don't have.
Okay. Anyway, I'll try to finish by 3:20, so we have 9 minutes more, and then you can ask a few questions afterwards if you like, and then the neurogenic factors. It can be either peripheral neuropathy or the spinal cord injury. The common causes of spinal cord injury are multiple sclerosis, syringomelia, and the transverse myelitis, and also disc disease, like the disc prolapse causing causing erectile dysfunction is fairly common. And then there can be central factors like stroke, tumors, and Parkinson's disease, and temporal lobe epilepsy. And don't forget the hormonal factors, the hypogonadism, primary, it could be primary or secondary, and then hyperprolactinemia. Hyperprolactinemia, often they have coexisting the delayed ejaculation, and sometimes galactorrhea, and it can be either microprolactinoma, and also the very low sexual desire. It could be microprolactinoma or macroprolactinoma. Then the anatomical conditions or the structural conditions leading to sexual erectile dysfunction. Peyronie's disease. Peyronie's disease is the thickening of the tunica albuginea and causing deformity, that is bending of the penis, together with pain and erectile dysfunction. Erectile dysfunction, this is fairly common than you think. And then diabetes and diabetes and smoking are the commonest risk factors, but often we can't find a reason for Peyronie's disease. Vascular anomalies, fibrosis of the corpora cavernosa, diabetes can cause that, and phimosis, also common. Please examine these men with erectile dysfunction. They wouldn't come to you saying that they have phimosis, and when you examine, you will see they have phimosis sites, and it's a significant number. You will detect even without patient coming to you saying that they have phimosis. Balanitis is very common in our setting. Commonly, it's fungal balanitis, and these conditions also can cause erectile dysfunction, because it causes pain and the difficulty in getting the erection and maintaining the erection, and also the penetration. So organic causes, you can go through the medication that causes erectile dysfunction. I will share the slides with the batch rep, and the CNS drugs, anti-androgens, 5-alpha reductase inhibitors, commonly used for to prevent hair loss, and also for prostate enlargement, BPH, benign prostatic hyperplasia, and alcohol abuse can cause ED, mild. It has several effects. Long-term alcohol abuse definitely can be detrimental. But in a young man with a lot of anxiety, small dose of alcohol can help reduce his anxiety, and can have better performance, but it's not something to be encouraged. Cigarette smoking is definitely harmful. And if I summarize, erectile dysfunction is common problem in men above 40. Main pathophysiological mechanism is endothelial dysfunction. It is predominantly due to organic causes, but psychological causes often coexist. In younger men, psychological causes are more common. ED predict early death by ischemic heart disease and vascular events. So therefore, we should not ignore it. I will quickly go through the assessment of a man with erectile dysfunction. First, we have to get a proper medical history, and then a sexual history, physical examination, including genital examination and investigations. And if there are psychological causes, you can do basic psychosexual counseling. If you think it's beyond your scope, you can refer them to a counselor or a psychiatrist even, or a specialist in this area. And then if they have cardiac symptoms, and the cardiological evaluation is needed, because there are two things. One is erectile dysfunction predicts the ischemic heart disease. That's like, it doesn't really, they don't have symptomatic cardiac problem. But other group is they have the cardiac problems. They have their own treatment for cardiological or the ischemic heart disease. And then before resuming sexual activity, they need to have proper evaluation, because a man should be able to tolerate a specific amount of physical activity to resume sexual activity. The easiest measure is if they can walk 1 mile in 20 minutes. Generally, they are safe for sexual activity with their regular partner. If they can climb 2 flights of stairs up and down briskly without any cardiac symptoms, then again they are safe for sexual activity with their regular partner, but not with someone else, because when they are with someone else, the excitement can be more, and the settings can be different. And often it's the different dynamics, and they may not tolerate that. So with the regular partner, if these two conditions could be met, they are generally safe. But then if they are not active to that extent, you have to always refer them to cardiologists to make sure that they are fit enough for sexual activity. Don't send everyone with the erectile dysfunction to cardiologist. I'm saying a patient with cardiac symptoms. Further investigations and testosterone therapy may be needed. if they have hypogonadism, you should check testosterone in men with erectile dysfunction, particularly if they have coexisting libido issues. But the libido issues are very common with erectile dysfunction, because when you don't get an erection, it leads to the low desire as well. But but if you're doing the testosterone, it has to be done 9 in the morning. Then we have to see if there is Peyronie's disease, and if there is Peyronie's disease, we need to refer them to a urologist. And it's very important for us to discuss what the patient wants and what the partner wants, and without imposing treatments and the different management. So in the management, we have to, after the initial evaluation, we have to optimize diabetic control. This is a good opportunity for us to start lifestyle modifications. It's never too late. Always encourage them to have proper lifestyle, that is exercise, proper diet, proper sleep, and managing stress, and giving up smoking. Those are absolutely essential in every man. The optimized comorbidity risk factors, like the hypertension management and the hyperlipidemia management, and these men needs to be looked into in terms of the medication they are on, and the medication can be modified with more erection friendly drugs like thiazide diuretics. Beta blockers can be replaced with the ARB blockers, and other newer antihypertensives. The first line treatment is PD5 inhibitor therapy. There are different classes of drugs: sildenafil, tadalafil, vardenafil, avanafil. What we have locally is sildenafil and tadalafil, and when they do not respond to one medication, you can always optimize it by increasing the dose, or giving them the right advice, guidance, when to take it, and proper psychosexual counseling. And the next line treatment is transurethral alprostadil, or intracavernosal injections, or vacuum device, or extracorporeal shockwave therapy. So we use intracavernosal injection. Commonest one available in Sri Lanka is papaverine. I use papaverine, which has good results, particularly men with the neurological problems. And the shockwave therapy or the ESWT is useful in men with the vascular erectile dysfunction. If one is contraindicated, but main contraindication for PD5 therapy is nitrate, coexisting nitrate therapy. So such men they cannot be given PD5 inhibitors, so they have to go for second line treatment straight away. And the last resort is penile implants, and that's when everything else fails. So I think I have come to the end of 1 hour, close to end of 1 hour. But if you are okay, anyone has having another commitment can move on. But I will try to explain in 5 minutes the premature ejaculation, because that is also a common problem. And the premature ejaculation, in order to make a diagnosis of premature ejaculation, there are 3 conditions that has to be met. One is short ejaculatory latency time, that is the time from vaginal penetration to ejaculation. According to ISSM, this time is 1 minute. If one ejaculates before 1 minute, 1 minute is considered short ejaculatory latency time. But we consider 1 to 2 minutes, that is in between 1 minute and 2 minutes, also short. provided it causes distress to the man as well as to the partner. And the second condition is inability to control, because sometimes men ejaculate too quickly because of the situation, not because lack of control or purposely. So in a situation where the woman has vaginismus or the woman has dyspareunia, a man can purposely ejaculate too quickly. And that is not premature ejaculation. So one has to have inability to control to make a diagnosis of premature ejaculation. And thirdly, distress about the condition, because simply having early ejaculation, simply having an inability to control his ejaculation doesn't mean that they need treatment, because if they're happy, it could be 30 seconds or 40 seconds. If both partners are happy, why should we worry? So it should cause distress to one or both partners. But if they come to seek help, that they have met that condition or the criteria. So let's look at the different kinds of premature ejaculation and how we manage them. First, PE, like ejaculated dysfunction, that is premature like ejaculated dysfunction, is when the man has a normal ejaculatory latency time. That is, he has more than 2 minutes. He can maintain for the erection for more than 2 minutes inside the vagina, but he's distressed, or his partner is distressed. That it's too short. So what they need is proper psychosexual counseling, reassurance, because they wouldn't know what is normal. They think that it has to last for 45 minutes, or there are misconceptions. And natural, the variable premature ejaculation is when the man ejaculates too quickly only in certain situations. That is like if you are having sex in the car, or in the setting where there is lack of privacy. In such situations, men can ejaculate too quickly, or with certain partners, men can ejaculate too quickly. That doesn't mean much. And so all they need is psychosexual counseling, reassurance, and the behavior therapy. And the behavior therapy, there is the technique that I have developed called Malavigi technique. Unfortunately, we don't have time. Maybe there'll be another opportunity someday to explain that. Then we have, if it did not belong to these two categories, we have to figure out whether it's secondary to erectile dysfunction or due to other medical causes. Because if premature ejaculation is secondary to erectile dysfunction, by managing the primary cause, that is erectile dysfunction, managing erectile dysfunction, you are treating the premature ejaculation as well. This is common, particularly in men who are having early premature ejaculation. Sorry, early erectile dysfunction. Early erectile dysfunction can be presented as premature ejaculation. Then, if they don't have causes existing, the erectile dysfunction or other primary cause like hyperthyroidism. Hyperthyroidism also can cause the premature ejaculation. Then we have to figure out whether it's acquired or lifelong. If it is acquired, the mainstay of treatment is psychotherapy, behavior therapy, pharmacotherapy. Often they need combination therapy. That is like, he has had a normal ejaculatory latency time, but developing it later in life. Then if it is lifelong, we start off with pharmacotherapy together with psychotherapy. The pharmacotherapy mainstay treatment is the SSRIs. So most of these men need an SSRI, most potent SSRI for long-standing or the lifelong premature ejaculation is paroxetine, and the other people who need a treatment on demand. Now we have dapagliflozin. That's the only licensed treatment for premature ejaculation. Dapagliflozin 30 milligram can be taken about 2 to 3 hours before sexual activity, and anyone who had been started on long-term treatment with SSRI can be attempted to be withdrawn out of the medication after 6 to 8 weeks. So I think the psychosexual counseling is very important, because it's not just the time, it's how they enjoy prior, that is foreplay, how they enjoy what kind of intimacy the couple has following the intercourse, because many men soon after ejaculation turn to the other side and sleep or just walk away. So these things affect the couple intimacy and the partner satisfaction more than the time. So thank you very much. I think we have exceeded a little beyond the time allocated. So if you have questions, I can quickly answer.
So one question.
Yeah.
So is there a way we can utilize the dual control method for psychotherapy or anything regarding sexual disorders?
Sorry, I didn't get it. The dual control method.
How is there a way which we can utilize that model, dual control model, to treat any sexual disorders?
Yes, see, like dual control method is using a questionnaire to assess excitation and inhibition. It's called CIS and CES, the sexual excitation scale and sexual inhibitory scale. So I have actually translated this to CIS to Sinhalese, Tamil, and several South Asian languages as well. I can, if you want, I can share it with you. Send me your email address. I will share CIS and CES. But dual control method is mostly for the research, because with that it's a long question here. It may not be practical. As you said, in identifying inhibitory factors and the excitatory factors in a normal patient, but you can learn some important things from it. But it's very important for research. Drop me an email. I will share you the dual control method model is based on these two questionnaires. I'll share those. There's a question. Is there a topical PD5 treatment for cardiac patients with erectile dysfunction? Because no, the topical PD5 inhibitors doesn't work even for the best for them is in local setting. Since we don't have adenofil, the injection therapy, the papaverine, intracavernosal injection therapy, and also the having a cardiac problem is not a contraindication for sex or PD5 inhibitors. That's the most important thing to remember. Someone who has had a heart attack or the myocardial infarction, or even someone who has had a bypass surgery can take PD5 inhibitors if they are fit enough for sexual activity. The fit enough is assessed by the physical activity, or if they can tolerate the third stage in the Bruce protocol, the exercise ECG. That means they are fit enough. So two conditions has to be met. One is they should be fit enough. Number two, they should not be on any nitrates. If those two conditions are met, then they are okay to take PDE5 inhibitors. Any other questions? All right. So thank you very much. If you all have any burning questions, anything to verify, drop me an email. You have it. It's elmalavigi@gmail.com. I'll try to respond whenever I can. Thank you very much. All the best. Look after your health and have a good sex life. Thank you. All the best.
Thank you, sir.
Thank you.